Good evening, ladies and gentlemen. Thank you so much for joining us for our webinar this evening. We will begin in just a few moments. We would love to give enough time for individuals to get comfortable, get logged on, and get ready for the webinar. On your screen, you will see a poll that will come up. If you would take a moment or two and fill that poll out for me, would greatly appreciate it. Dr. Esparza will be able to use this information later to be able to identify how to further help and assist individuals going forward. This is an anonymous webinar. We do not see your name, we don't see your face. If you have a question during the webinar, we do ask that you put that question into the Q&A, not in the chat, but in the Q&A. And at the end of the presentation, Dr. Esparza will answer your questions for you. Again, if you're just now coming on, we do ask that you fill out the poll that's on the screen in front of you. And in just a few moments, we will begin. Once again, ladies and gentlemen, thank you so much for joining us. This is a recording that we're actually doing. If you are joining us, we greatly appreciate your time this evening. If you see the poll come up on the screen, if you will go ahead and fill that out for us, we greatly appreciate it. But at this time, we are going to go ahead and get started. So I am going to pass the microphone over to Dr. Esparza, who's going to introduce himself to you and present to you this evening. Dr. Esparza.
Good evening, everyone. I'm gonna start with the next slide. Let me see if I have control of it. Yes, okay. So yeah, good evening. My name is Amir Esparza. I'm a board certified general surgeon and with subspecialty on colon and rectal surgery. Currently, I'm working in Phoenix at the Center for Colorectal Disease of Arizona, providing all types of services. I am going to just quickly remind you what usually colorectal surgeons do. Mainly, we're trained for big surgeries, for abdominal surgeries, robotic surgeries, for cancer, diverticular disease, as well anything has to do with anal rectal disorders, with hemorrhoids, fissures, fistulas. But today we're going to concentrate in the one of my passions, actually, which is pelvic floor. We do colonoscopies as well as pelvic floor testing and treatment for it. Among pelvic floor issues, we have fecal incontinence, and that's what we're going to talk today for the next few minutes. So I'm not sure if you ever heard of yourself or anyone saying that, they're very concerned, patients are very concerned on leaving home or afraid to go to a celebration or out on a date or have a road trip. They're always wondering where the bathroom is. And if there is no bathroom, this makes them very uncomfortable and embarrassing to be asking for it. 54% of patients suffering with this have never even discussed this with a doctor. And this is what we're going to talk about today. And the reason, mainly the reason is because culturally, the majority of the patients never knew that it was there was a solution. And surprising enough, also some primary doctors and physicians will not know either that is a solution for it, but it is very simple. We're gonna go over it. 1 in 12 patients have fecal incontinence. This is very, very, very common. Approximately 21 million patients in the United States have this. It happens to men and women of all ages. It can cause serious problems, which includes low quality of life, depression, just feeling embarrassment, and just sadness. So it is a very important problem that we need to address. So traditionally, it was thought that the reason why we have fecal incontinence is because of aging, but that's not something that is inevitable. We do have solutions, and the main symptoms that patients have is involuntary loss of stool, the control of holding their stool, feeling the urgency that they have to be very close to a bathroom, planning activities around that, again, needing to be a close home, using pads, and sometimes this is combined with urinary incontinence, which the treatment they're gonna be telling you works for both. This is just symptoms of your body's telling you that something is going on and you should be addressing it. So long time ago, almost 2 years ago, I developed this pathway that I usually talk to the patients when they come to my office, and I explain what the process is on someone who is diagnosed with fecal incontinence. So basically, I divide this pamphlet, which by the way, I give the patients to take home, on the treatment for fecal incontinence is divided in conservative treatments and advanced therapies. So if we go into the conservative therapies, first of all, to prove someone who has fecal incontinence, we go over the medical history, we do an examination, feeling the sphincter muscles to see if they're weak, and their coordinates, as well as an anal manometry. It was a very simple test where we just connect a probe into a computer, and it tells us how strong your muscle, how weak your muscle is. This just is another tool that helps us evaluate and diagnose someone with fecal incontinence. So part of the conservative therapy that we ask patients to start with is incrementing their fiber supplements, their fiber intake. If they have diarrhea, to take anti-diarrhea medications, dietary changes, which, for example, if they have certain foods that they can avoid that causes them to have diarrhea, we'll have to stop that, and schedule stooling, trying to plan their bowel movements based on time of the day. Adding to this, and very important, is pelvic floor physical therapy, like Kegel exercises. So this is a therapy that usually we try for a few weeks. The majority of patients who come see me have tried this already in the past, and they are looking for something else to help with this problem. And this is what we're gonna focus more on, is the advanced therapy. So Medtronics, which is the company who we're having logistically put together this talk today, was one of the pioneers of the sacral nerve stimulator. Sacral nerve stimulator is basically a pacemaker for the pelvic floor. So I'm gonna go back to this test, this slide, but this stimulator, which is the pacemaker for the pelvic floor, sends signals to the nerves that are innervating the floor of the pelvis, and reconnects the brain as well to the sphincters. Also stimulates these nerves and have them have multiple contractions throughout the day that you aren't aware of it. So basically, bowel-brain communication is improved, and the bowel control improves as well. The efficiency and the timing for this is very impressive, because now when we go back, this secondary stimulation therapy is divided in 2 stages. Stage 1 and stage 2. Basically, the insurance companies wants to identify which patient will benefit the most with this therapy. We're gonna go on data, but over 90% of the patients improve significantly after this therapy. But still, they want us to check and make sure you are the candidate for it. So the first thing we do is a simple test done in the office. It takes 15 minutes, where temporarily we will leave a little tiny wire at the root of the nerve of the pelvic floor, connected to a battery that is external, that you'll be carrying it for 1 week. A lot of the patients get significantly better the day after, 2 days later, so they don't even need to keep it that long there. After that test is done, we want to make sure if the patient has a greater than 50% improvement or less than 50% improvement. If you have greater than 50% improvement, which is, by the way, the great majority of patients, then I will place a permanent implant, which is a very, very small, a little over an inch device that goes underneath your skin in your butt cheek. So all of these procedures have nothing to do with the rectum or the anus. Everything is done in the lower back. The majority of patients do significantly better from this, but in cases where there's not improvement, there's other stuff of procedures we can do, like sphincteroplasty or surgical repair, that doesn't have the same improvement or outcome. This is a picture here on the right of how the interstem looks. So basically, it's a little over an inch, very thin device. This one contains the battery on, and also the stimulus to send through this wire into the root of the nerve, as selected here. There are 2 types of devices: rechargeable, non-rechargeable. With the new generations of the non-rechargeable, the battery lasts over 15 years, and when the battery is needed to change, exchanging battery is a less than 20-minute procedure as well. But also there is that rechargeable option for patients who are preferred to do that. Both of them, new generation, are MRI compatible, which was the biggest improvement from previous generations, because in the past they were not compatible with MRI and there were issues with that, but now these are MRI compatible. As you know, most of the stuff that I said here we talked about, but basically the therapy has been used since 2011, and there are multiple articles, and as of right now is the gold standard and standard of care for fecal incontinence is the sacral nerve stimulator. Data that I promised you to show you, 89% of people using the Medtronic bowel control therapy experience long-term success. The quality of life significantly improved, and you know, it's a safe and effective therapy that has been around us for over a decade, now almost 15 years around. This is a quick explanation. If this is the right therapy for you, again, if you have chronic history of fecal incontinence, this is we're talking about urinary incontinence as well as the fecal incontinence. You have already tried medications and lifestyle changes, and you feel like these treatments haven't really done much for you, you are a candidate for it. Now, when I leave now on this page, this is my phone number of my office. I'll be happy. This is one of my passions on treatment. and I'll be happy to take care of any of the patients who need it.
Thank you so much. At this time, we are going to open up the question and answers. So if there is anyone that has a question, we do invite you to go ahead and put that question into the chat. I am also launching a second poll that I would very much appreciate if you would fill out for us. Again, we're going to use this information for Dr. Esparza to be able to assist and help going forward. So I'm going to open up the question with the first question for you, Dr. Esparza. Are you ready? The first question, you're on mute.
Yeah.
All right. So the first question is, what is the risk associated with InterStem?
Minimal risks. The stage 1, which is done in the office, is a tiny little wire that goes through a small needle. That one doesn't have really much of risk. We're working on areas that there's no main vessels or anything. For the stage 2, which when we're gonna put the tiny little battery underneath the skin, there is a risk of infection. Infection is very, very rare, approximately 1 in 1,000 patients. Majority of them who have a risk factor like chronic smoking or diabetes, those ones have a high risk. But wound infection is easily treated with antibiotics, but otherwise there's not really much major risks. The second stage, by the way, is done under sedation. It's the same type of sedation we use for colonoscopy, so it's minimal sedation. So there's no even general anesthesia for it. It's outpatient. It takes half an hour. Patient goes home same day.
Perfect. Thank you. Next question is, how long does the device last? And I suppose I mean the battery.
The battery can last up to 15 years. Depends of the amplitude of the energy that it will require, but it's an average of 15 years.
Thank you. Next question is, will I be able to have an MRI if I have this device?
Yes, MRI compatible. You will be going with a smartphone with you. That one you don't have to keep it with you all the time, but there is a MRI setting that you just have to click on it, and that's it.
Next question. How long before I would be able to resume activities if I have the device put in?
Yeah, actually it goes back. There's another question that is similar. It says, can I go back to regular physical activities after the procedure? The answer to that is yes. So the procedure again is a half an hour procedure. It's very a small incision in the skin. You can return to regular activities, physical activity like exercises. I prefer patients to start doing that aggressively 2 weeks after the procedure, after I check the skin and I check the wound, making sure it's all working. But these devices are protected for even impact. So for impact sports, because if there is a decent amount of space or distance between the skin and the device, that direct impact doesn't really cause much damage to it.
Another question is, will insurance cover the cost?
Yes, every step of the procedure is submitted to the insurance for an authorization, and we don't perform the procedures unless the insurance authorizes it. And so far, all of the procedures have been authorized for the majority of the insurance that I work with.
There's another one in there. Give me a moment. The question is the device noticeable through the skin?
No, we try to have it underneath the skin in the subcutaneous tissue. Obviously, there are patients who, for a particular reason, have lost a lot of weight or are otherwise very thin. You know, potentially could maybe feel it, but otherwise, it shouldn't be noticeable through the skin.
Next question is this a permanent treatment? Does this assist in improvement?
I'm sorry, can you repeat the question?
Is this a permanent treatment? And does this assist in improvement? Will this give improvement? I would assume that's what they're asking.
Okay, so none of these tests or procedures are permanent. All of them have the option to have revised or removed if the patient wanted to. But it's interesting because when we do the stage 1, which is done in the office, I do have to remove the temporary wire of the patient. And thus, a lot of the patients cannot wait until they have the second stage because that period of time they go back to what their symptoms were. So they're really looking forward for the day of the permanent. And we call permanent is because it goes underneath the skin. But again, those are not technically permanent because they can be removed at any time, at any point. I haven't met a patient yet that requests it to have it removed.
Okay. That is all the, well, here's another one. Will the device improve pelvic floor muscle strength?
100%. Yes, it does. It does. It is basically doing Kegel exercises for you multiple times a minute. You're not even noticing it, but your sphincter is doing all day. You're noticing it, and you know, after repetition of muscle, your pelvic floor gets stronger.
I think that might have been our last question. I'll give it just a moment more to see if someone throws another question out there. And I think there is one. Yes. Does this help with women after pregnancy?
I have had patients from all ages, you know, starting from 25, I think it was the youngest one, up to 90 years old, and it has to be evaluated depending of what we call pregnancy or postpartum or stuff. But this is not something that is recommended on a patient who is pregnant or is doing pregnancy.
Next question, how long have you worked doing this procedure? How long have you performed this procedure?
So I was introduced to it right after it was taken out into the outed market. I have been on the pioneers of this in Chicago. So I was introduced to it in 2015, almost 10 years, almost at the same time it was on company, and I've been doing this for a long time. You know, as I was a resident, I was already working with this, so potentially the same time it has been out.
Thank you. And the next question says, are there any complications from having the implant?
Yeah, there can be complications, and the complication that we don't like is skin infection. Skin infection, the worst case scenario, which is very, very, very rare. Worst case scenario, we have to remove the device temporarily. But it doesn't really happen. Again, patients who are heavy smokers or have uncontrolled diabetes fall into the higher risk. But we do this sterilely, and we give pre-operative antibiotics, so the risk is very low. But yes, that would be the risk.
Okay.
I think the
So,
last question is, I read the last one. It says, can complications happen years after? And no, it's the only thing that can happen is many, many years after the battery can end and we have to replace the battery, but not really much of a, I haven't really seen complication years after.
So as I'm closing out, and if there's going to be any last minute questions, we'll accept those. But please, if you are interested in making an appointment or have further questions, Dr. Esparza is open for taking appointments. His phone number is on the screen. He does work out of a couple of different offices, so you may find one very convenient to where you are. If you would like to get more information or have a conversation with an individual themselves that have already had the implant, you can talk with one of them if you log on to innerstemambassador.com. And that way they can sign up to be able to talk with you and answer any further questions personally for you. If you want to take an additional survey, you can go to controlleaks.com/bio, and there are some more questions that will be asked to you to help you further identify if this is something you may want to have a conversation about. So at this time, we don't have any more questions. I would like to very much thank Dr. Esparza for his time this evening. We greatly appreciate your time, sir, and this valuable information that you've given.
No, thank you. Thank you, Kenny, for putting this together. Appreciate it.
Absolutely. Thank you. And one of the participants has said thank you.
Oh, you're welcome.
Thank you so much. Have a good night.
Okay, good night.